it is my pleasure to present our distinguished presenter. Dr. Brian J. Carrie was born and raised in Scotland. He attended the University of Aberdeen Medical School, completing his postgraduate training in internal medicine and nephrology. Thereafter, he came to Stanford initially as a medical fellow and then as an adjunct clinical professor of medicine in the nephrology division. Over the years, he has served as medical director of the artificial kidney unit and associate chief of nephrology at Santa Clara Valley Medical Center. While in medical school, Dr. Carrie received many academic prizes in such fields as forensic medicine, social medicine, pediatrics, surgery, and orthopedics. He has received many honors, including the European Medical Student Scholarship, Carnegie Traveling Scholarship, British Medical Student Association Scholarship, National Kidney Foundation Northern California Fellowship, and a National Institutes of Health Fellowship. He has authored over 25 manuscripts and abstracts in peer-reviewed journals, some of which include the American Journal of Medicine, Kidney International, and the American Journal of Kidney Disease. He now works with El Camino Renal Medical Group, which covers the complete spectrum of adult nephrology, and works out of El Camino Hospital in Mountain View. Today, Dr. Carrie will be presenting on the topic, Understanding Your Lab Results. We are thrilled to have him here, and please give a warm welcome to Dr. Brian J.
Thank you very much for the opportunity to talk today. You notice I'm carrying a Pepsi. This is not a good example for kidney patients. Way too much phosphorus. I'm going to go through lab results. We have an information management system in our office, and it's a secured system. So ideally, I was going to do a cut and paste onto another document, but for security reasons, it wouldn't let me do that. So I've redacted out the patient's data so that these are anonymous. First thing to do is make sure it's your own lab result that you're looking at. So often, not so often, but from time to time, we get labs that are misfiled. The second page of a 3-page document might refer to a different patient. So that's why I highlight this first section here, just to make sure that you're dealing with the right database. I'm going to divide it up into different sections, just as they come to us from the lab. And I'll be happy to take any questions, perhaps would complete each individual set of lab data, and then I could field questions on that. So in the hematology section, we start off with the white blood cell count, and I'll take you through the test name is here, the patient result is there, and then most labs will highlight whether it's an abnormal reading or a normal reading, and then they'll give you the normal range, and this is the units of measurement. So white blood count, that tells you is there an infection going on. It goes up where there's an infection. If you're a transplant patient on anti-rejection therapy, we want to make sure the white count doesn't become too low, and then you're susceptible to intercurrent infections. Hemoglobin, a measure of level of anemia or otherwise. Normal range is about 12 to 15 grams. Most kidney patients get a little bit anemic because there's a hormone that's produced by the kidneys called erythropoietin, and as kidney function goes down, kidneys produce less erythropoietin, so people can end up becoming anemic. And there are ESAs, erythrocyte stimulating agents, that we can give that help to raise the hemoglobin. Hematocrit is also a measure of red blood cells. And usually the hematocrit is about 3 times the hemoglobin level. So we'll look at hemoglobin or hematocrit as markers of anemia. The next section looks at the MCV, MCH, MCHC. These are measures of what we call the red blood cell indices. I can't see my cursor. There it is. These are measures of the size and the shape of the red blood cells, and certain changes on those things can tell us what sort of anemia a patient may be dealing with. The MCV is a measure of the size of the red blood cells. In iron deficiency anemia, that number goes down. In vitamin B12 deficiency or folic acid deficiency, that number goes up. The RDW is a measure of the red cell width distribution. It's a measure of how many big cells, small cells, and various sized cells are present. And that can be useful in some forms of anemia, especially iron deficiency anemia, where that number tends to go up. Platelet count is a measure of the little tiny platelets in the bloodstream which are involved in the initiation of the clotting mechanism. Many of us take aspirin for general vascular health, and aspirin works by cutting down, reducing the stickiness of these platelets. The platelets are the initiator, really, of the clotting process. Next down, the differential. This looks at the...
Question?
Sure.
So I'm looking at my lab results, and top of the page it says CBC without differential. So
that just depends how your doc orders it. We can order a CBC would contain all of the stuff you see here,
right.
all of this part, and the breakdown of what the various white cell series is, and then they'll actually look at them and count them as well. A hemogram, for example, we just include this batch. I know Stanford offers all sorts of different choices. We can have a CBC without differential, CBC without platelet count. Most other labs, if you order a CBC, you get the works.
Yeah, okay. So my doctor decided, no, we're going to need that.
Yeah, and for routine following, we don't always get these ones.
Well, I was a donor, so.
So you're perceived as healthy.
Mine has, it says automated.
This is all done through a thing called it's not an autoanalyzer, it's done by machine that does all of this stuff automatically. And then sometimes we'll have a pathologist will actually do what we call a manual differential. And I don't know if there's one on here. No, that's all you get on this one.
But it doesn't give the results there.
I
I don't have the result, it just says automated.
I'm not sure I understood.
And the differential type, it says automated, but I don't have the results.
Oh, okay. Well, the automated differential would be this, and these are all different types of white blood cells. So maybe that's on a second page that you didn't get, or something like that.
Perhaps I get it, but I don't.
Then we go to the chemistry section. Again, just make sure it's your labs. And we start off with the sodium. Everybody thinks the blood sodium level is a measure of how much salt you take in. That's actually not true. The sodium level is a measure of water metabolism. For example, if you drink 3 gallons of water right away, you'll dilute down your serum sodium before the body's corrective mechanisms can take care of it. Frequently, we'll see dialysis patients who've taken in a little bit more fluid than they should since the last treatment will come in with a lowish sodium, maybe 130, give or take, because they've diluted down their sodium and their kidneys are not, they've taken in fluid, their kidneys are not able to get rid of the fluid, and so that dilutes down the sodium level. A low sodium isn't really a problem until it gets down to about 120, give or take. Next one is potassium. As kidney patients, I'm sure you're all aware of potassium, very important. Normally we take in our dietary potassium intake, probably 90% of it is excreted by the kidneys, 10%, give or take, goes out in sweat, perspiration, stool losses. So kidney function, very important in the regulation of potassium levels. I'll go down to the CO2, which is really a measure of the acid-base balance in the blood. We'll also refer to that one as the bicarbonate. And the kidneys are intimately involved in acid-base regulation. And frequently, as kidney function goes down, we'll see the bicarb level will go down as well. The chloride it changes in the opposite direction to the bicarb. As bicarb goes down, chloride goes up, just to prevent sparks from happening in the blood. Blood glucose, very important for diabetic patients. Normal fasting glucose is up to about 100. Postprandial glucose could go up to 150, give or take, without somebody necessarily being diabetic. The next numbers down, the BUN and the creatinine, are measures of kidney function. BUN stands for blood urea nitrogen. And it's not quite such a good marker of kidney function as is the serum creatinine, because there are certain things that can affect the BUN, such as the patient's level of hydration, such as the patient's protein intake. High protein intake, the BUN will go up higher. In the setting of kidney disease, low protein intake, the BUN will be lower, because BUN it's a breakdown product of protein. Liver disease, patients who've got advanced liver disease, the liver doesn't metabolize the protein, so the BUN is lower. So it's not a very pure marker of kidney function. And as nephrologists, we seldom look at it even. I mean, patients will ask me what their BUN is, and I'll have to say, well, geez, I didn't really notice. But the creatinine is the thing that all of us focus on. That is a very, very, very good marker of kidney function. Normal is up to 1.0. Sorry, for this lab. Some other labs, 1.1, 1.2. So if you're getting your blood tests done at different labs, just make sure that you take a look at what is the normal range for that particular lab, so that you can get an idea of whether your creatinine has actually changed or not. Yes?
Creatinine is a single chemical, is that correct?
It's a breakdown. It's produced by muscle metabolism. It's a pretty pure kidney marker. It's filtered by the glomerulus, and there's a small proportion of it is secreted by the tubules, the kidney tubules, like maybe 2-3% is tubular creatinine secretion. The other large part is representative of filtration across the glomerulus, the sieving part of kidney. It is influenced by muscle mass. Men will produce between 15 and 20 milligrams of creatinine per kilogram of body weight per day. Women will produce 10 to 15 milligrams per kilogram of body weight creatinine per day. But it's not really influenced too much by sulfate or oxalate or any other sort of metabolic pathways.
This creatinine level for a patient who is on dialysis, there's a variation, a lot of variation. Sometimes it is 2.5, sometimes it becomes 4.
Oh,
So how
yeah.
do you-
There's always a bit of noise. These things never seem to be, you know, it depends a little bit on patients' level of hydration and things like that. Depends if they're taking other medications. Frequently, I sort of look on it as your patient has a usual creatinine plus or minus maybe 0.2, something like that. I think you quoted 2.5 and
Yeah.
then 4.
Sometimes-
That's more than I'd expect with just pure biological variation, right? You know, is the patient dehydrated? Have they been started on some other medication that's reduced kidney function? Have they been put on a diuretic, for example? Are they taking over-the-counter pain medicines, Advil, ibuprofen, Motrin, those sorts of drugs?
If some 3 months ago or 4 months ago it was 3.5 and now it is 2.5, that doesn't mean the kidney function is
Is better.
better even for a dialysis patient? For a dialysis patient?
Well, you see, that it depends when the blood test is drawn relative to when the patient had their last dialysis. Right after dialysis, the creatinine might be down to 1 or 2, but 3 days since your last dialysis, it might be up at 10 or 12.
Doctor, I'm not sure whether everybody can hear the question, so perhaps you
Oh,
could
sure.
just
Oh,
repeat
yes,
those.
yes,
Thank
yes.
you.
Okay. The creatinine is a marker of kidney function, and then there's a calculation that is now appearing on most lab results. It looks at the estimated GFR. GFR stands for glomerular filtration rate. That's really the most important thing that we look at when we're thinking kidney function. It's a calculated number that takes into account the serum creatinine, the patient's age, the patient's gender, their ethnicity. Some of the calculations will also take into account the BUN and the blood protein level, either total protein or albumin. If you notice, we get 2 different results. One is if you're an African American. If this were an African American patient with serum creatinine 1.3, their estimated GFR would be about 55 mils per minute. Whereas if it's a non-African American ethnicity, that would come out at about 45 mils per minute. Reason for that variation is, in general, African Americans have got more muscle mass than the rest of us. So that's why that one is as it is. Then also on this sheet we've got some of the other chemicals, the calcium level, which is quite important in kidney patients. And most labs will now give us what we call the corrected or the adjusted calcium level, which is it's a normalized value adjusted for a serum albumin of 4.0. See, those patients got an albumin of 3.6, therefore the calcium level corrects up by about 0.3. Total protein and albumin are very important, especially in dialysis patients. Having a good albumin level is correlated with much better outcomes in dialysis patients than a low albumin. So if we see a dialysis patient with low albumin, we jump all over it and try to get them better nourished.
Excuse me, Doctor, I'm
Yeah.
sorry. Based on that, what's the word? On
Result?
that example that you're using, his creatinine would be 1.0?
No, it's 1.3.
Okay.
And the creatinine value here,
Right.
creatinine is 1.3.
Okay,
Normal range is 0.4 to 1.0.
Oh, okay,
Um,
so that's what it is.
Usually, by the time we see an elevation of the creatinine value,
Mhm.
somebody has lost close to 50% of their kidney function.
Right.
So at the low end, subtle changes in the serum creatinine
Right.
value really represent a big change
Right.
in underlying kidney function.
Okay.
At the other end, when your serum creatinine, let's say, goes from 4
Right.
to 8,
Right.
that probably represents a drop in overall kidney function
Right.
from about 25 down to 12.
Okay.
And that was one of the reasons that all the kidney groups pressurized the lab to put in this calculation
Right.
so that non-nephrologists would be alerted that a serum creatinine of 1.3 represents fairly significant
Right.
decline of kidney function.
Right. So I'm sorry. So with this example again, what would be too high?
1.3 is too high.
Right. Because his
You
the
want,
average.
you want to have as much kidney function as you possibly
Right,
can
right,
have.
Right.
Most people
Right.
probably have a serum creatinine level that's about 0.6 or 0.7.
Okay.
So a 1.3
Right.
is about twice that normal value, which then represents about half
Right.
of the kidney function that they should have.
Okay. So that's good to know.
Phosphorus, sorry, there's a question up there?
Yeah, so is this the level same from different lab to different lab, or if they are different? Because I see in the lab 0.4 to 1.5.
Exactly, yes. As I think I mentioned, I just happened to take the El Camino Hospital labs because they are set out in a clearer way, and I thought it would be more illustrative for this presentation. But LabCorp or Quest or Palo Alto Medical Foundation all have slightly different normal lab values. I have seen up as high as 1.4, 1.5 from some labs. It depends on, there are different ways of measuring all of these using different reagents. And so each reagent gives you a slightly different normal range.
And in the transplant patient, what is the acceptable range?
I mean, as long as it's good enough that you don't need to go back on dialysis, that would be the sort of the crass sort of response. But obviously, the lower the serum creatinine is, the better. You know, in the early days when cyclosporin came out, which would be in the early 80s, I think, in this country, the average one-year serum creatinine was about 1.8 to 1.9 post-transplant. We're actually getting, I think, much better results than that now using different anti-rejection techniques. Yes?
Is there a formula you could write down that would take, you could plug in serum, the creatinine number level and figure out what your kidney function percentage
I'll be
is?
happy to give you that. It's called the MDRD equation. It's available online, and I don't have it on this
If
thing.
it's online, I could go find
I've got it in my phone, which I've had to switch off because it's interfering with this other thing in my pocket. Phosphorus level, very important in dialysis patients and in kidney patients in general. There's good data that outcome of dialysis patients relates to the phosphorus level. People with a serum phosphorus of 3.5 have got better survival figures than people with phosphorus of 4.5, who've got better survival figures than patients with a serum phosphorus of 5.5. And that data is out there in big studies. These are measures of liver function. The bilirubin is the sort of the serum bile level, if you like. If you're jaundiced, you turn yellow, The bilirubin level, instead of being less than 1.2 or 1.3, might go up to 10 or 20 and you turn a mellow shade of yellow. These are other markers of liver function. The AST and the ALT really are measures of hepatocellular function. The alkaline phosphatase, it is produced both by bone and by liver. In some people who've got bone disease associated with kidney disease, we'll see the alkaline phosphatase level go up. In people who've got a gallstone that's blocking the drainage of their liver, we'll see this number go up. The creatine kinase, that's a measure of muscle enzyme activity that we'll normally check in somebody who's on a statin group of drugs. Magnesium level, magnesium can accumulate in kidney patients, so we like to be sure that we know what we're dealing with there. I seem to have lost my cursor here as well. So this is another patient, just sections are set out similarly, CBC, differential, absolute count, to look at the iron stores. I mentioned that kidney patients tend to be anemic. If we're going to be giving them the agents to stimulate the bone marrow to produce red blood cells, we want to make sure that their iron stores are adequate. So we look at the iron binding capacity and percentage saturation, and the ferritin, which is, I think, in the next page. Hemoglobin A1C is a long-range marker of what the patient's blood glucose level has been. Non-diabetic patients, 6.2 or less. Diabetic patients, we try to get it as low as possible, but getting it under 7 is a good target. This patient obviously is diabetic and has not been adequately controlled. Uric acid is another substance that we measure, and uric acid is a substance that can precipitate out in our joints and might cause gout. And in our gouty patients, we try to get the blood uric acid level below about 6, because if it's higher than that, that can be associated with long-term damage to the joints. Urinalysis. This is just a simple, straightforward urine collection that we can check in the office, or it can be checked in the lab. We obviously look at the color of it and what it looks like. And then these are all checked by dipstick all the way down to there. So those little multiple test dipsticks will measure all of these ones. And this is obviously an abnormal one. It looks a bit cloudy, it's a little bit concentrated. There's a trace of protein in it, moderate amount of blood. And this is a measure of white blood cells. There's a trace there. And yeah. So this patient, if we see that or do that, we would be suspicious this patient has a urinary tract infection. And indeed, this is the culture thing coming through that shows that this patient has a urinary infection. This tells us what the bugs are. Usually, we don't get too excited until these numbers are more than 100,000 per cubic millimeter. But in a transplant patient who's immunosuppressed, we will treat these numbers. These are the different choices of antibiotics, and this looks at whether the bug is sensitive or resistant to the particular antibiotic.
I have a question.
Yeah.
What does trace, protein trace in urinary vessels mean? Or imply?
It might mean something or it might mean nothing. The dipsticks that we use are incredibly sensitive, and for people who really don't have anything major amiss with their kidneys, will sometimes get dipstick trace positivity. Usually, what I would do when I see a little bit of protein in the urine is get a 24-hour collection and just see is it something or is it nothing. I think that might be a good segue into this one. Yeah. This is a 24-hour urine collection, which is looking at the creatinine clearance, and that's it. That's the number there. And it looks like it hasn't yet been, it's still, this is a partial one, it's still pending, obviously. So a 24-hour collection can tell us the overall function of kidneys. The normal range is usually from about 75 to 125, give or take, for different labs. The midpoint of that spread is about 100. So you frequently hear nephrologists talking about percentage of kidney function. What they're really meaning is the creatinine clearance. And then we can test the urine for protein, and this is looking at what the protein concentration is, 10.2 milligrams per deciliter, and this looks at the rate of production. So in either of those parameters, this patient is putting out too much protein in the urine and clearly has something amiss with their kidneys. This is a more common urine culture result, more than 100,000 per cubic millimeter. And then again, this one doesn't give us the sensitivity. It's on the next page that we have it, sensitivity. So then we pick an antibiotic that the patient wasn't allergic to, but the bug was sensitive to, and ideally we would give it in oral form rather than by injection, unless the patient's in the hospital, in which case we can give it easily by injection. This looks at some thyroid function studies, and phosphorus here, the reason I brought that up, it's a Stanford lab, John Scandling ordered it. It's obviously somebody with kidney disease, creatinine of 5.2, Stanford lab less than 1.2, I think the El Camino lab was less than 1.0. So got to look at those differences. This patient's phosphorus is way too high at 7.6. And they've had their thyroid checked free T4, that means the free thyroxine level that's in the blood. That's the active thyroid hormone that is produced by the thyroid gland. And it's driven by the thyroid stimulating hormone, which is released by the hypothalamic pituitary axis. And that substance stimulates the production of thyroid hormone. This is a bit of a low level. This patient may well be on thyroid replacement hormone. In an underactive thyroid, we'll usually see this number elevated. I could talk about this all day. I don't want to exceed you guys' attention span.
Question?
Yes?
Is there a link between a thyroid function and kidney disease?
Really not. I mean, is there a link between thyroid disease and kidney disease? Really not. Maybe a slightly more low underactive thyroid in dialysis patients than in non-dialysis patients. Again, I'm not sure if that's because of the kidney disease or because 50% of the people now starting dialysis are doing so because they've got diabetes. And sometimes people will have abnormalities of pancreas and underactivity of thyroid. I'm not sure I've seen a convincing article that has said, hey, kidney disease causes thyroid disease. Certainly, thyroid disease would not cause kidney disease. Sometimes we'll see people who've got abnormal kidney function. We're trying to figure out why that is. We'll get ultrasounds to take a look at the kidneys, see what they look like, and then we'll get some of the other markers of other diseases and disorders that might cause kidney problems. And I think you had an immunologist talking to you last time or the time before, and he probably was talking about some of this stuff. Does this look familiar to you all? No? Okay. We'll attempt to look at the ANCA, anti-neutrophilic cytoplasmic antibody. That's a marker of whether somebody has got inflammation in little tiny blood vessels, what we call vasculitis. Because if they do, that can damage kidneys. So these are all forms of ANCA that we might take a look at. Amazing. I put this up for just as a segue into cholesterol. You know, when we look at the different ways of doing a lipid panel. If you do a fasting lipid panel, then you can do a calculation that works out the LDL. Some labs will offer a direct measurement of the LDL, which doesn't require fasting. So we're interested in the total numbers, and you know, to give us some of the normal things here. The most important things in this sort of lipid panel are what's the total, what is the HDL cholesterol, which is the good cholesterol. For every 1 milligram per deciliter that this number rises above 40, a patient's risk of getting heart disease goes down by 2%. If we can exert strategies to get this number up to 60, for example, I know right away that I've cut down this patient's risk of a vascular event by 40%. In kidney patients, the LDL cholesterol is very important. These are the, I think, American Heart Association guidelines, 0 to 99, for the normal non-kidney patient. There are certain categories of patient where we try to get the LDL cholesterol down to 60 to 70 or better or lower. And those would be patients who've got diabetes, patients who've got high blood pressure, male patients who smoke, and people with kidney disease. Worldwide, I understand that nephrologists are the biggest prescribers of the statin group of drugs. Because anytime I see a patient with a creatinine, I don't know what this patient's creatinine is, but the last one was 1.3. If I have a new patient comes into the office with a 1.3 creatinine, and I see an LDL of 105, I mean, they don't leave the office without starting the statin. And then we check them back 6 weeks later, check their liver tests, check their muscle enzyme tests, and check, of course, their fasting lipid values. And this one also has a completed creatinine clearance. That's the 24-hour collection that's based on the serum creatinine, the amount of creatinine in the urine volume. And this one is down a little bit at 88. The normal range for this lab is 97 to 137. I think I quoted the Alpino lab was 75 to 125. And this is a measure of 24-hour urine protein, usually up to 150. Some labs will say 125 is normal, milligrams per 24 hours. You know, this is, what, 5 times the upper limit of normal, which as protein in the urine goes, isn't bad. frequently we're seeing people with 8,000, 10,000, 12,000 milligrams of protein in the urine. We can check various virus levels. I think this was a patient who was being evaluated for why did they have kidney disease. So we checked their hepatitis C virus to see if it's positive, because sometimes people who are hep C carriers can end up getting kidney abnormalities. This person has an elevated TSH. That's the hormone that gets produced by the brain to stimulate the thyroid to produce more active thyroid hormone. This number is up a little bit, so I suspect that they probably have a little bit of underactivity of thyroid, even though it's still in the normal range. It's just taking more effort by the brain to stimulate the adequate blood levels of the active thyroid hormone. Parathyroid hormone is produced by the parathyroid glands. They're called parathyroid because they're adjacent to the main thyroid gland. There are 4 tiny glands that are in back of the thyroid, independent both embryologically and functionally from thyroid. And in patients with kidney disease, phosphorus is excreted by kidneys. As kidney function goes down, phosphorus level tends to go up. As phosphorus level in the blood goes up, calcium level in the blood tends to go down. Those two things stimulate the parathyroid gland to crank out more parathyroid hormone. Parathyroid hormone will then pull calcium out of the bones and will stimulate the kidneys to excrete more phosphorus. So that tends to normalize the phosphorus-calcium balance, but at the expense of a high PTH level. And in the long haul, this is not good for bones because they become thinner, brittle, more brittle, can fracture. And so the approach to somebody with this sort of level of PTH is get the phosphorus under really good control by using phosphorus binders. Get them onto a vitamin D analog, usually a pill, or if they're on dialysis, we can give the vitamin D by injection into the blood return line. And sometimes we'll add in another medication called a calcimimetic agent called Sensipar that suppresses the release of parathyroid hormone by the parathyroid glands, and that can make the bones stronger in the long run.
There are different types of vitamin D.
Yes?
Are any of them preferred for high parathyroid levels?
Yeah. We check the 25 hydroxy vitamin D level. That's the vitamin D that is present in certain foodstuffs, dairy products in particular, and which gets generated by ultraviolet light on our skin. And there's a lot of stuff coming out about it in the last couple of years that really would suggest to us that 25 hydroxy vitamin D really does all the things that Linus Pauling thought vitamin C was going to do. Most of us, even living in California, we wear wide-brimmed hats when we're outside. We wear a lot of sunscreen because we don't want to get wrinkles and skin cancers. And most of us have got low 25 hydroxy vitamin D levels. That has been shown to be associated with premature vascular disease and increased level of cancers. So we're checking most patients' 25 hydroxy vitamin D levels, and if they're less than 35, we're putting them onto supplemental vitamin D. There's another vitamin D that gets produced by the kidneys. The way vitamin D gets manufactured, something happens with ultraviolet light in the skin, that then gets passed through the liver where you get a 1-hydroxyl thing tagged on in the 25 position. That then moves to the kidneys, which then change it into 1,25-dihydroxy vitamin D. And that's the step that the kidney patients can't muster, so that's why we give them vitamin D supplements with dialysis. If they've got a transplant, if their kidney function is good enough that they don't need dialysis, they probably are going to be producing enough of the 125, but we'll usually check that level, and then if they're not yet on dialysis, we'll give them a pill by mouth, and that can be in the form of Rocaltrol or Zempla, or they're different agents. And again, those are pretty expensive, but those companies now have coupons that can limit your copay to just $5 a month on those vitamin D analogs. Yes?
I have a question. What kind of labs are we looking at when you begin to consider dialysis?
We'll be looking at the chemistries, the general chemistry, and in particular, we would be looking at the blood creatinine value, and as that number goes up, that's one of the indicators of when somebody might need dialysis. We also look at their acid-base balance, what is their bicarbonate level, and we might be looking at their potassium level. Some people really get very high potassium levels because of certain other abnormalities in their kidneys, independent of just the kidney's ability to excrete the creatinine and the BUN type poisons. And so somebody like that might go on dialysis a little bit sooner.
So it's like a 3-level creatinine would probably be...
A 3-level in somebody in your age group and ethnicity would probably represent overall kidney function of about 15%, I would guesstimate. And that's sort of stage 5 chronic kidney disease. You get down to about 10 or 12, one's usually looking at starting dialysis. Obviously, I'm just making a broad generalization without knowing, more about your lab stuff. Yes?
Dr. Carrie, in your clinical experience, do you know if there's a correlation between elevated proteinuria in pregnancy? My wife had high protein, and we've done 2 24-hour urine collections.
Yeah.
First one was about 1,200, and the second one was basically the same as 1,100. Is that expected to go down after delivery, or?
Up to 1,000 milligrams is not uncommon in pregnancy and may not reflect any underlying kidney disease. It takes about 12 weeks for the physiological changes that occur in the kidneys with pregnancy to go back to the non-pregnant values. So anytime one sees a patient with any sort of kidney abnormality or high blood pressure in pregnancy, we ask the question, well, what were they like before they got pregnant? And if they were normal, then it's probably just hypertension in pregnancy or proteinuria in pregnancy or diabetes in pregnancy. But we check them again at about 12 weeks, usually with a 12 weeks post-delivery with a 24-hour collection. People who get gestational diabetes, the moms, are at increased risk of getting diabetes later in life. That's an excellent question. The question is, somebody with kidney disease gets ESAs, erythrocyte-stimulating agents, to raise their hemoglobin and correct their anemia. Is there a risk of going too high? Absolutely. And I'll take you through the history. I guess erythropoietin became available, seems to me like in about 1990, give or take. And so we gave people a lot of erythropoietin to try and get their hemoglobins into the normal range. Amgen, which brought out the EPO, did a study looking at high target, low target. And it was absolutely counterintuitive, but the people who had the high target hemoglobins did not do so well as the people with the lower targets. All that stuff has now been sliced and diced and reevaluated. And we know that if we push somebody's hemoglobin, if we aim for somebody to have a hemoglobin above 12, they're at a slightly increased risk of getting heart disease and stroke. So we're really targeting between 11 and 12 as the target hemoglobin, which corresponds to a hematocrit of 33 to 36.
Is ferritin also measured that?
Ferritin is a totally independent measure. There was a little bit of controversy surrounding iron replacement about 10-15 years ago. It seemed that people who were replaced with intravenous iron to push their ferritin level more than about 500 were at increased risk of getting infections. Now, further studies have shown that that really is not a major risk. And our guidelines suggest that we can we can give iron intravenously or orally up to a ferritin level of 800 to 1,000. Sometimes the ferritin level will shoot up if somebody has inflammatory disease for whatever reason or an infection. Yes?
I'm asking this question because you mentioned that 3 days after dialysis, somebody's creatinine level could go up to 10 or 12. If their creatinine level is being carefully calibrated to allow for different labs, so it's been measured by one hospital, one lab, and it's 10, 10, 10, 10, and then jumps to 12 on somebody who is not yet on dialysis. How serious is that?
Well, that's a real change. It represents, what, a 20% change in kidney function. So there's clearly something going on. Is it, and the question is it a change in underlying kidney function? Has the patient had some sort of intercurrent illness, even just a cold or flu or malaise? We'll frequently see the creatinine will bounce up surrounding something like that. Have they taken some over-the-counter pain pills, Motrin, ibuprofen, Advil? That group of drugs will make the blood creatinine value go up.
Zithromax? Zithromax?
Wouldn't independently do that, but the reason for why the patient was taking the Zithromax in the first place, probably an upper respiratory tract infection, could well cause the creatinine value to go up. So I see that a lot, and usually I say to the patient, let's check again. If you're asymptomatic, let's check another creatinine in a couple of weeks. We do that with our transplant patients as well. If we see a blip in the creatinine, say, well, is it for real, or was it for, by that I mean, is it for real a change of underlying kidney function, or is it just something else was amiss? So then we would recheck the creatinine in a week or two.
Thank you.
I've had that happen before.
Oh yeah, you've been down that road many times.
And going in after you've exercised and having your labs drawn and being dehydrated will do that as well.
I've seen it from people who've gone out the night before, partied too much. Their labs will be all sorts of shape the next morning. Yes?
Will an event involving a kidney stone cause a sudden elevation in creatinine?
Absolutely.
And could we repeat the question?
Oh, sorry. Will a kidney stone event can it cause a rise in creatinine? Absolutely, especially if, you know, our kidneys are sort of here, we all know where our bladder is, and there are two tubes called ureters that go from kidney down to bladder. And if you've got a kidney stone that passes, and that would manifest itself as usually as pain starting in the kidney area, and then as it moves down the ureter, it tends to move around the side. Colicky pain comes in waves, and if a kidney stone goes down into ureter, it potentially could block off one kidney entirely, which would then lead to a doubling of your baseline creatinine value. So if your usual creatinine was 1, you knock off the excretion from one kidney, you'll end up with, just mathematically end up with a creatinine of 2.
But is it reversible after this?
Oh yeah, as long as somebody hasn't had a total obstruction for more than about 6 weeks. 6 weeks seems to be the cutoff in animal experimental models and in human observation, that if somebody's had a complete blockage for 6 weeks, we're not going to get that kidney back to where it was before. But usually if somebody's having kidney stone pain, they don't wait 6 weeks. It's like childbirth, I'm told. And you know, the way kidney stones are treated in this country, the patient comes into the ER, we put an IV in their arm, we hydrate them, which gets them passing a lot more urine. We give them intravenous pain medicine, opiates usually, and by stimulating the urine flow, hopefully the kidney stone gets passed spontaneously. One of my patients was traveling in Europe and had a kidney stone in Germany. He went into the ER and they gave him 3 liters of beer to drink. That was the combination diuretic and pain medicine.
Let's hope he didn't have gout, because alcohol is bad.
So maybe that's how we keep the healthcare costs down.
That's elevated by medication, pain medication. Is it damaging to the kidneys?
Pain medicines can be damaging to kidneys. Depends on the pain medicine. The group that I've talked about, what we call the non-steroidal anti-inflammatory group of drugs, such as Motrin, Advil, Aleve, ibuprofen, Celebrex, all of those medications change the blood flow at the microscopic level that goes through the glomeruli, which are the filtering parts of kidneys. So the overall kidney function always goes down when people take that group of drugs. If they're starting off with normal kidney function, it doesn't matter. But if they're starting off with only 20% kidney function, then they might end up going down to 15, 14% while they're on the medicines. If they haven't been taking the medicines for a long period of time, then probably when they stop taking them, their kidney function will go back to where it was previously.
Well, specifically Vicodin.
Vicodin does not affect kidneys at all. Vicodin is a combination drug of acetaminophen and an opiate derivative. And acetaminophen, Tylenol, is quite safe for kidneys. There'll probably be about 500 articles out in the literature showing how safe it is, and I'm aware that there's one that says, hey, maybe it's a little bit dicey. But so the huge body of evidence favors it's okay to take Tylenol for kidneys. Vicodin does not affect kidney function. Causes constipation, some people get nauseated with it, can cause sleepiness, mental status changes. Acetaminophen, Tylenol is quite safe so long as you don't take too much of it. If you take too much of it, then you risk knocking off your liver. Currently, the guidelines are not to exceed 4,000 milligrams per day of Tylenol. But for people who might have a hepatitis C infection or hepatitis B infection, or maybe drink too much alcohol, probably 3,000 milligrams will be coming out as the new guideline. And we have to be really careful with Tylenol because it's present in so many things. You know, Tylenol cough syrup, Tylenol PM to help you to sleep. It's a combination of Tylenol and Benadryl, Tylenol extra strength, Tylenol arthritic formulation, and it can add up.
Someone that has a high GFR, what is the recommended periodic time to have a lab test?
If your GFR is high, that means that's good. Your GFR is...
I guess low.
Okay. Yeah, if your creatinine value is high, your blood creatinine value is high, that means your your GFR is low. And again, it just depends how high. You know, if I've got somebody who's, as nephrologists, we look at absolute value and we look at trend line. You know, if somebody's had a creatinine of 5 or 7 forever, then it's reasonable to not check them quite so often. But if their trend line is changing, say if there were 5 3 months ago, and then there were 6, and now there's 7, that's happening over a 3-month time interval, and we're not able to identify anything that we can do that will slow that rise, then we know that they're going to start to get symptomatic in the foreseeable future. So we'll see them more often. And frequently when I think somebody's getting close to needing dialysis, I'll see them in the office maybe every 2 weeks and get blood tests every 2 weeks. And I'll describe to them what the symptoms are of the buildup of kidney poisons, and if they should get those symptoms, then to be sure to phone me. If ever you see people out in the street holding their hands out like that to see if they do that, you know they've probably come in to see me in the office, because I coach them all to do that.
What does that mean?
That's what we call a flapping tremor, and it's quite different than that some people get a little bit of a tremor from anti-rejection drugs or for other reasons. But when you hold your hands out and bend them back like that, you get this sort of, you can get a flap like that, and that means either you've got a build-up of kidney poisons, liver poisons, or you've taken some med that doesn't agree with you.
Yeah, I believe we had a question here and
Yes.
then over there.
Yes. That's you.
Thank you. So for kidney, if you have several kidneys in his stones in his kidney, would increased hydration be part of a treatment? And if so, would that damage renal function?
No. If somebody's got normal kidney function, we can
1.7 creatinine was last year.
1.7. Yeah, you're not going to probably run into fluid overload with that.
Last year.
Yeah. The strategy for kidney stone management is to get a value. Kidney stones happen for a reason, and it's basically just applied biochemistry. There's either too much of something in the urine that's precipitating out and causing the stone, or there's not enough of some of the other agents that tend to help prevent kidney stone formation. And I'm just going to crank up my computer again because I've got some stone data on here as well. But the best way to minimize the chance of having a kidney stone is to make sure that hydration is adequate, that people are drinking plenty of fluid. There's a so-called stone belt in the southern part of the United States, running across Texas, Arizona, California. Hot, dry places. People get dehydrated, they lose all of their ingested fluid, comes out through their skin. Urine is more concentrated, and then things start to precipitate out and cause kidney stones. So if we see a stone patient, we're looking at how much are they drinking, and then we look at the constituents of their urine. Oh, I forgot to put in the thing. So does that answer your question?
So if he should increase hydration for the kidney stone, would that at the same time damage renal function?
It should not, absolutely not. In general, drinking more helps to preserve and protect kidney function, provided one's kidney function is good enough that you can get rid of the stuff, the fluid. The question really was, what is the minimum dialysis that we can do to keep this person alive? Because dialysis in the early stages was really quite heroic and difficult, and there were all sorts of access problems and things like that. So dialysis really started as a once-a-week thing. When I started it in the UK, we were doing it twice a week. came to this country, and in this country at that time they were doing it 3 times a week. And I could tell from personal observation that the 3 times a week patient who was routinely dialyzing 3 times a week was much better off than the patient who was routinely dialyzing twice a week. Now we're even looking at doing 6 times a week dialysis treatments, short, frequent dialysis treatments, 2 hours, give or take, every day with Sundays off. And those patients do incredibly well. There's a group in France that does long, slow, low-flow dialysis 3 times a week, usually for about 8 hours at a time, and those patients do incredibly well. So mostly the standard in this country would be 3 times a week dialysis, looking at what we call the kinetics, the KT over V, and making sure that that number is at least 1.3 or 1.4 or higher. And that's a measure of it's sort of a measure of kidney function, as it were. And it takes into account the kidney function that the patient might get from dialysis and their underlying native kidney function. We have a number of patients who are lucky enough to have enough underlying kidney function that they can get away with just twice a week dialysis and have these kinetic numbers be in a satisfactory range.
And truly the last question, right here.
Do you expect different kinds of lab results from drug-induced kidney disease and other types of kidney disease?
Really not. Let's walk you through some of the drug-induced kidney diseases. If somebody has a true allergic reaction to a medication, to an antibiotic, for example, they might have a skin rash, and then on the blood tests we would see that one of their white blood cells might be elevated, things called eosinophils. So that might give us a clue that we're dealing with something a little bit allergic. But the effect on kidney function itself, we wouldn't be able to tell from the creatinine value whether that was the creatinine's gone up because of the allergic reaction. We couldn't tell if the creatinine had gone up because the patient had taken one of those over-the-counter pain meds that I talked about.
I'm speaking specifically of lithium-induced.
Lithium has some other... lithium is an interesting drug. It can damage kidney function while people are taking it. There's what we call a fairly low therapeutic index. That means the blood level at which you get a therapeutic response is not that far away from the blood level at which you get a toxic response. And people can be taking the same amount of lithium day in, day out, but let's say they get dehydrated or something else affects kidney function because lithium gets excreted by kidneys. Then the blood level goes up, and then they can get some effects on the kidneys there. Too much lithium can cause your thyroid to become underactive. Lithium can damage the tubules in the kidneys, which are involved in regulating what the urine volume is and how concentrated the urine is. And lithium can also have effects on metabolism as well. So in somebody who's still taking lithium, we want to make sure that we check their thyroid, we check their calcium, we check their kidney function frequently. The good thing about lithium is that if somebody gets what we call a lithium hit, that is, their kidneys get damaged by lithium, if you stop taking the lithium, usually the kidney function remains quite stable thereafter. It doesn't progress, doesn't get worse. And there are studies, and this is a frequent question that we have to address in somebody who's on lithium and who's got a kidney abnormality. There are studies that show that other drugs can accomplish the same benefits, the same therapeutic outcome that can be accomplished with lithium. although speaking to individual patients, they feel like their control is not quite so smooth on those other agents as it is on the lithium. If somebody has a lithium hit and isn't getting the benefit from the other drugs, then we'll try having them continue with lithium, but making sure that their blood levels are in the low end of the therapeutic range to prevent them going too high and getting the hit.
Thank you. Thank you very much, Dr. Brian J. So it's been a very, very helpful and informative 90 minutes. How often do we have access to a doctor of this caliber to present to us and answer questions for 90 minutes? It's a great treat and extremely helpful. Thank you, Doctor.